My name is Victoria. I'm going to be the nurse practitioner doing your care today. Nice to meet you. Do you have any major medical complaints that bring you into the clinic today? No? Okay, good. So today I'm going to be doing a complete thoracic and respiratory examination on you. I'm going to explain step by step what I'm doing as I go, but before I get started I want to make sure I have your permission to do this. I also need to let you know that this video is going to be uploaded onto YouTube. The only person who's going to see it is my instructor. Do I still have your permission to continue? Yes. Perfect. So with any examination, the first thing that we always do is inspect. So I'm going to be inspecting your chest wall, your sternum, make sure that there's no abnormalities. As I'm looking at you, I see a normal rise and fall of your chest. Your trachea is midline. I don't see any kind of deviation. Everything looks really good there. Overall inspection of your skin, I don't see any cyanosis. Continuing with the inspection, I'm going to check your extremities. I'm looking at your overall color. I want to check your cap refill on all your fingers, which should be less than 3 seconds. And while I'm doing this, I'm looking for any kind of clubbing or any other signs of impaired oxygen exchange. Again, on this side, overall color seems completely normal, warm to touch. Cap refill on all fingers is less than 3 seconds, and I'm not noting any kind of clubbing or cyanosis or anything that would indicate any kind of disease process. So after inspection, the next thing I'm going to do is palpation. When I'm palpating, what I'm going to do is I'm going to fill in your intercostal spaces. This is what we call costochondral tenderness. So bear with me, I'm just going to work my way down. And at any point that you feel any kind of tenderness, if you do, let me know. Anything there? Alright, so just so you know, everything I'm going to do anteriorly, and then we're going to repeat the whole process posteriorly. So along with palpation, I'm going to be checking, okay, so I'm palpating. The next thing I'm going to do, I'm going to check your diaphragmatic excursion. So what I want you to do, I want you to lay back. Okay? Mm-hmm. Before I do that, I'm going to check your breathing here. What I'm going to do is I'm going to put my hands on your chest here, on your rib cage, and I want you to take a deep breath. And out. So what I'm looking for when I do this is to make sure that there is good rise and fall of the chest bilaterally. My thumbs, when she takes a deep breath, should go apart and they should come back very equally. And that all seems very normal. While I have you in this position, I'm going to go ahead and do what we call percussion. So when I'm doing percussion, I'm going to take my non-dominant hand, I'm going to put my middle finger, and I'm going to thump. I should hear a very resonant sound. The reason I'm hearing a very resonant sound is because the lung is an air-filled capsule. And if I hear any kind of dullness or anything like that, can I raise this up a little bit? If I hear any kind of dullness, that could be I'm over some bone, or I am over some consolidation. That's why we would hear any kind of dull sounds when we do that. Continuing on, while I'm doing percussion, I'm going to check your diaphragmatic excursion. So what I want you to do, I want you to take a nice deep breath and hold it. So I'm listening anteriorly to when I no longer hear dullness or resonance, and when I hit dullness, and that's about right there. Breathe, relax. Let's do the same thing on this side. Take a nice deep breath. Hearing resonance there, resonance. Okay, I hear some dullness. So at this point, I can see here, I'm going to mark it by this mole. I would normally make a mark on the patient. I'm going to have you take a deep breath, and I'm going to have you exhale out all the air and then hold your breath. Finding the point I just had. I'm gonna move up, dull, resonance. Take a deep breath. Let it all out. Dull, resonance. And that's about 3 centimeters on a normal patient. That's completely normal. Anywhere between 3 and 6 centimeters is completely normal for a diaphragmatic excursion. So after we have done our inspection, our palpation, and our percussion, we're going to go ahead and move on to our auscultation. Go ahead and sit up for me, Ann. Go ahead and turn. So when we're auscultating, we are going to do both the bell and the diaphragm. We're going to start up high because this is the apex of our lungs. Anytime my stethoscope touches you, I want you to take a deep breath. Deep breath. Good. Good. And can you just reach down and pull up your breast tissue? Okay, so what I'm listening for there is vesicular sounds, which would be normal. I'm ruling out any advantageous sounds, which would include wheezes, crackles, bronchi, rales, any of that. And of course, at this point, I don't hear any of those sounds on you. At this point, we're going to do what we call a tactile fermentus. So what I'm going to have you do, I'm going to press my fingers against you, say 99. 99. So what I'm feeling for when I do this test is for a normal, gentle vibration that I feel against my hand. I felt that everywhere. If I was in a place that was over bone or some place that had some consolidation, the vibrations would be a lot less. But that seems completely normal for you right now. All right, and if you don't mind, let's move right over here and flip around, because now we're going to do the same thing, and we are going to do it posteriorly. Go ahead and turn a little more. So continuing on with the tactile fermentus, go ahead and say 99. 99. 99. 99. 99. Perfect. So again, normal gentle vibrations. If I was over consolidation, I would have a decreased sensation of that. So obviously anything starts with an inspection. I'm looking at the general rise and fall of her lungs while she breathes. It seems completely normal. I'm going to go ahead and test here. I'm going to squeeze the skin together. I'm at the 10th rib. Take a deep breath, and that should have a normal separation of my thumbs and down, and they should go together perfectly. Again, if I had any kind of indication of a pneumothorax, there wouldn't be a normal rise and fall. Next thing I'm going to be checking again is costochondral tenderness. I'm going to go ahead and palpate here. Tell me if you feel any kind of tenderness. No? All right. So moving on, we're going to go ahead and do percussion all the way around the back. I'm going to take my non-dominant finger, going in intercostal spaces. I don't want to go between bone. I want to hit twice, and I should hear a nice resonant sound. Important to do this bilaterally and compare. If I heard any dullness, that would be an indication of me being over the bone or some consolidation in the lungs. So now I'm going to measure your diaphragmatic excursion. So what I'm going to have you do is take a nice big deep breath and hold it. And so I'm going to keep going down till I hear dullness. So right there, breathe. And this is right at the line of her sports bra, so that will be my marker. Same thing on the other side. Nice deep breath. I'm going to keep going till I hear dullness. Again, right at the border of her sports bra. So this time, Ann, I'm going to have you take a nice deep breath and blow it out all out, and then at the end of it, I'm going to have you hold your breath. Big breath. I'm going to let it all out. And I'm going to start at the line that I had, dullness. Good. Same thing on the other side, nice deep breath. Out. Dullness. All right, you're approximately 4 centimeters, which is completely normal, like I said. Anybody who has no lung disease should be between 3 and 6 centimeters. So lastly, what I'm going to do is I'm going to do an auscultation of your posterior lungs. I'm going to do this with the bell and the diaphragm. I'm going to start up high, the apex of your lungs. Deep breath out. Again, listening for vesicular sounds, which would be normal. If I hear any advantageous sounds, which would include wheezing, any rhonchi, rales, anything like that, that would alert me to do a further examination. But at this time, I think we are completely done with your respiratory and thoracic examination. Do you have any questions? You can turn around. No? You feel okay? Okay. All right, thank you for your help.